All right, welcome to the Med-Inspired video lectures series, where we'll be discussing some of the most common chief complaints among emergency medicine and pre-hospital medicine. And today we're going to talk about one of my favorite subjects, and that is syncope. When is it serious? So, the three components to assess for when we're talking about the syncope patient is the history, the physical exam, and the 12-lead EKG. History, physical exam, and 12-lead EKG. And we're going to use these three things to help us differentiate between the life-threatening causes of syncope and the not-so-life-threatening causes of syncope. So, we have to first distinguish, was this actually a syncopal episode or was this a seizure? And this happens very frequently. The patient will have a syncopal episode. They'll have a period of shaking that lasts 15, 20, 30 seconds. And bystanders will frequently misinterpret this as a seizure and will tell you that the patient had a seizure. But we're going to use our history and our physical exam to look for key clues to help tease out the difference. Now, in order to do that, we have to first know exactly what syncope is. So syncope is a transient loss of consciousness and postural tone with a rapid return to baseline. Now, these are two key words in here, transient and rapid. So you pass out, you fall to the ground, and it's brief, and then you have a rapid return to your normal baseline mental status. So if the patient is still confused 5, 10, 15 minutes after the episode, this is not syncope. This is something else like a seizure and needs to be investigated more. So there's all kinds of different reasons why a patient would have a syncopal episode. So there's vasovagal, there's situational, there's orthostatic, and there's cardiovascular. Now, vasovagal syncope. So vasovagal syncope, this is the classic, prolonged standing or kneeling in a warm or crowded place. The patient will frequently have a prodrome of nausea. They'll tell you they'll feel a narrowing of vision. They'll get sweaty, and then they pass out. Situational syncope. This occurs from micturition, defecation, things like coughing, carotid sinus pressure, things like turning the head too rapidly or shaving can stimulate the vagus nerve and cause a syncopal episode. Orthostatic hypotension is very common, and this is frequently triggered by blood pressure meds. So when you think orthostatic hypotension, I want you to think medication-induced. I want you to think of things like dehydration and alcohol consumption. And then we need to talk about cardiovascular. So these are things like dysrhythmias, structural heart disease, and ischemia. And really what we're trying to figure out in the assessment of a patient with syncope was this a cardiac cause of syncope or a non-cardiac cause? Now, here's some clues in our physical exam we can use to help differentiate between syncope and seizure. So things like urinary incontinence can point towards seizure over syncope. Things like the lateralized tongue laceration is highly, highly specific for a seizure syndrome. And then we're always going to tailor our history gathering towards these red flags. So we're looking for these red flags right here. Exertional syncope. So this is the patient who was running, lifting weights, They were exerting themselves, and then they passed out. We always need to investigate this more because this could point to a more serious etiology of the syncope. Anyone with an abnormal ECG, this is a no-brainer, needs to be investigated further. Anyone with a history of heart disease or heart failure, CHF, prior MI. Any syncope with no prodrome. So this is very important to distinguish between a cardiac and non-cardiac cause of syncope. So like we discussed earlier, the patient with vasovagal syncope, they'll get this nausea, they'll kind of have a narrowing of vision, they'll feel it coming on, and then they tell you they woke up on the ground. This is versus the patient who says, I was just walking along and just bam, next thing I know, I'm on the ground, I'm waking up and people are standing above me. The patient with no prodrome is more concerning for a cardiac cause. Anyone who passes out sitting or lying down needs to be investigated further. So it's very common to pass out from, standing too long with knees locked. But anytime you pass out sitting down or laying down, you should be concerned. The syncope plus calls. So this is the syncope plus chest pain, the syncope plus shortness of breath, the syncope plus abdominal pain. This points towards a more serious etiology, right? This could be a AAA or a dissection, a pulmonary embolism. And then we need to always ask about the family history of sudden death. So anyone under the age of 40 who had a sudden cardiac arrest, we need to ask about this history because this could point towards more a congenital cause, a congenital heart abnormality that runs in the family. So we're going to get our 12-lead EKG. So this is our money right here, 12-lead EKG. And we're going to look for all the usual suspects, right? We're going to look for things like AV blocks. We're going to look for bradycardias and tachycardias. We're looking for signs of ischemia. But we're also going to look for the big five. The big five is WPW, or Wolff-Parkinson's-White syndrome. We're going to look for a HOCM. This is hypertrophic obstructive cardiomyopathy. We're going to look for long QT syndrome, and we'll discuss this more. We have two types of long QT syndrome, and we're going to look for Brugada, and we're going to look for ARVD, so arrhythmogenic right ventricular dysplasia, also known as arrhythmogenic right ventricular cardiomyopathy. And this is actually the second leading cause of death in young people behind HOCM. So let's take a moment to look at this ECG and think to yourself for a moment. We look up here, we see it looks like sinus. We have a P wave in lead 2. It's inverted in AVR. We have this little blip over here in V1, and we have inverted T waves. And this is ARVC, so arrhythmogenic right ventricular cardiomyopathy. And like I discussed before, it's the second leading cause of death in young people behind HOCM. And it's a genetic disorder. It leads to these fibrofatty changes in the heart. And the classic ECG findings are inverted T waves in your right precordial leads, so V1, V2, and V3. You will get a QRS in lead 1 greater than 110 milliseconds. And you will get these epsilon waves. It's a low amplitude notch after the QRS and before the T wave in V1, V2, and V3. I like to call it a blip. So it's this little blip right after the QRS and before the T wave. It's highly specific for ARVC, although it's only seen in about 30% of cases. The T waves are actually more prevalent. about 75% of patients with ARVC will have inverted T waves. So here's another EKG. You can see we have inverted T's in V1, V2, V3, extending all the way out to V5. And you can see sort of what looks like a little blip up there after the QRS in V1. But this is in a patient with a syncopal episode. And they did go on to have ARVC. Here's another example. So you don't see the epsilon wave, but you do see the inverted T waves in the right precordial leads, V1, V2, and V3. Another example of ARVC. And here's another one in a patient with a syncopal episode. And you see inverted T's. You see a widened QRS in 1. And this is classic for ARVC. All right, let's talk about our second ECG pattern we should always be looking for, and that is the infamous Brugada syndrome, discovered by the Brugada brothers back in 1990, or in the 90s, I believe. I think it was like 92. But they discovered it was very prevalent in the Asian population. Asian males actually were dying, having sudden cardiac death. And they were having these syncopal episodes, and they were going into polymorphic VTAC. But there's 3 patterns to Brugada syndrome. There's a type 1, a type 2, and a type 3. We're going to focus on the type 1 and type 2. So type 1 is a coved type pattern. Almost kind of looks like a bundled branches type pattern. And then you have your type 2, which is a saddleback pattern. And then type 3 is a combination of the two. This is actually a channelopathy. Here you see type 1, V1, and V2. You see this coved type pattern. And this is in a patient with syncope. Here's another one. This is your type 2 or your saddleback. You see this kind of, it looks like a saddle or a depressed area in V1 and V2. And this is classic for Brugada. All right, let's talk about our third pattern we should always be looking for in syncope, and that is HOCM, hypertrophic obstructive cardiomyopathy. And this is the #1 leading cause of sudden cardiac arrest in young people. You see this classically in the very in-shape athlete, the football player, the marathon runner. They're young, they're in shape, and then they suddenly die from a cardiac arrest. So we should always be screening for this. And it's a genetic disorder. It leads to an obstruction of the left ventricular outflow tract, which causes the patient to have a syncopal episode, and they get this thickening of the myocardium, which decreases the area inside of the ventricles and decreases cardiac output. The classic pattern for HOCM is these deep inverted T waves and deep narrow Q waves. They can often mimic the Q wave of an MI, but they're typically larger than the Q waves that you see in MI. And you'll get these big QRS voltages. So I want you to think big QRS voltages, inverted T waves, and dagger-like Q waves in your lateral leads and your high lateral leads. And here we see diffuse T-wave inversion all over with big QRS voltages. And this was a case of HOCM. Here we have more of our classic dagger-like Q waves. So if you look over here in V5 and V6, and then up in lead 1 or high lateral lead, we see these long dagger-like Q waves. And this is classic for hokum. Here is another example of hokum, large QRS voltages, and then dagger-like Q waves. Look at V6, V5, V4, and then our high lateral leads 1 and AVL, deep, narrow Qs, is pathognomonic for hokum. All right, let's talk about our next ECG pattern in the syncopal patient, and that is WPW. So the way I like to remember this in my head, I like to think W stands for wave. You're going to have this delta wave, right? The delta wave is this slurred upstroke to the QRS. You'll get a P wave. I think P stands for PR interval. So the PR interval will be shortened, and then you'll get W for wide. So you'll have a wide QRS. Now there's different types of WPW. There's like antidromic and orthodromic, and it's from an accessory pathway in the heart. So you won't always get a wide QRS, but you will always have a shortened PR interval. So you look for that shortened PR interval. And if you notice in this EKG, we see a very short PR interval. The P wave is almost into the QRS, and you see that classic delta wave. If you look over here in V4 and V6, you see how it's slurred up, and that's classic for WPW. Here's another example, very short PR interval, or delta wave, and this we should always look for this in our syncopal patient. Now let's talk about our other EKG pattern that we should look for in the syncopal patient, and that is long QT syndrome. So if you look at this EKG, you can see that the QTC is very long. It's pretty much, if we look right here, it's about half the distance between these two QRSs. And that's one way that you can assess for long QT syndrome. So you measure where the end of the T wave is, and if it's at or greater than half of the two QRSs, that is considered a long QT. You can also look at the top of your rhythm strip at the numbers at the top, and you can it'll tell you what the QTC is. You always want to look for the corrected QT, and anything really greater than 500 is worrisome. 450 in kids, 500 in adults. And this really predisposes the patient to polymorphic VTAC and sudden cardiac death. Now you have a congenital long QT, so you're born with this condition, or you can also have acquired cases. And acquired can be from all sorts of things. It can be from a whole laundry list of medications, antipsychotics, antibiotics, antihistamines, antiarrhythmics like amiodarone and sotalol. These can all cause an acquired long QT syndrome. And then you can also get it from the hypos, the hypomagnesium, the hypokalemia, and the hypocalcemia. And there's some other conditions too, things like hypothermia, myocarditis, but mainly it's going to be meds, and your low electrolytes can cause an acquired QT syndrome. Here's another example. If you look at the top of this ECG, you'll see that the QTC is 512. All right, well, that ends our medical lecture. I hope you enjoyed Syncope. When is it serious? You can find us at www.bmedinspired.com. Go to our Facebook channel or our Instagram and like us. And we'll talk to you guys later. Bye now.